Good evening and welcome to Sashbear Expert Education Series. Anita Federici is a clinical psychologist and the owner of the Center for Psychology and Emotion Regulation. She serves an adjunct faculty position at York University and is a distinguished fellow of the Academy for Eating Disorders. She has provided more than 375 lectures, workshops, and invited talks on eating disorders, MED-DBT, compassionate care for complex needs, and developing differential care pathways that integrate biotemperament-based approaches, experts by experience, and ethical care. She works extensively with hospitals and community organizations nationally and internationally, offering team training, implementation support, and program development, with a special focus on creating differential care pathways for clients who do not respond to traditional treatment approaches. Her work has been presented at international conferences and published in peer-reviewed journals and invited book chapters.
Thank you
Welcome.
so much. Thanks, Carol. Thanks, everybody at Sashbear for inviting me back. That is such an honor. I got to speak here a number of years ago, and Sashbear is an organization that I just have so much admiration for. So thank you for having me back. So I was telling the Sashbear team, I said, geez, I only have 45 minutes to present on this topic that I've been studying for 20, 25 years. So I'm going to do my best to highlight some key pieces that I would like everybody to know when we think about the relationship between borderline personality disorder and eating disorders. And that's what we're going to be talking about today. It was interesting when I was putting this together. I thought, okay, what would I want to highlight? And I think there are three main things. One is, what is the overlap? So that, as a caregiver, or even if there's people here that are struggling tonight with both of these things, I think it's important to understand why these things coexist, and what we know about them, because they actually fall together quite frequently. And often we don't know that the eating disorder is present. We don't always know that it's there, but it's a big part of emotion regulation and so on. I want to talk about, I'm going to give you a crash course in eating disorders. I can't do it justice in the time that I have, but I want you to know what the eating disorders are, what the difference between them are, and what are the warning signs? How can you use your observe and describe skills to notice whether or not there may be eating disorder symptoms or issues going on for those that you are caring for? And then, are there DBT skills that might help us? And the short answer is absolutely. So I'm going to highlight a few of my go-tos as we get there. A little bit of background, because I always find it interesting when I'm going to a speaking event, and I'm always curious about who the speaker is or how on earth they got to this place that they're writing about or they're developing treatments about. And so what you see on the right of the screen here is actually my PhD dissertation. And I moved recently, and it was just last week that this came out of a box. And I thought, I'm going to take a picture of it. I'm going to show people at this event, because this was done in 2008, but it started in 2004. And I was looking at what could we do for this subgroup of people who had borderline personality disorder and eating disorders. And here I am 20 years later talking more about it. And that actually makes me really happy, because I'm so passionate about this particular intersection. But the work of my dissertation started actually way earlier. I grew up academically in eating disorder programs, standard eating disorder programs. And so what you see on the top left was my master's thesis, where I was curious about, well, how come some people were recovering from an eating disorder and other people weren't, even after intensive treatment? Didn't really make sense to me what was happening. And what I started to learn was that there were actually some pretty significant differences, different subgroups that needed different care pathways. But I didn't fully understand in those years what was really going on. I knew there was something about emotion regulation that was happening. And it wasn't until I got a job in the Borderline Personality Disorders Clinic at the Center for Addiction and Mental Health in downtown Toronto back in 2003 and 4 that I realized that there was this whole other section of DBT and BPD that was really needed in the eating disorder field that wasn't there. And this has been the last sort of 20 plus years of my journey, to the point now where my colleague Lucine Wisniewski and I just wrote the MED-DBT book, It's with the publishers. It's still got months to go, but it's been the culmination of 20 years and a lot of the material that I'm going to be presenting tonight. So it takes a long time to figure out what to do and what's happening and why some people respond and other people don't. So in order to get at the overlap between BPD and eating disorders, I wanted to start with a bit of a crash course on what on earth eating disorders are, because there's a lot of misconceptions out there, right? So I'm not sure what everybody here knows about eating disorders, but most people don't realize that there's actually 7 different types of eating disorders that are recognized. Most people hear eating disorder and think anorexia, bulimia, maybe binge eating, maybe ARFID, but mostly people think of anorexia and bulimia. So the term eating disorder is an umbrella term for a number of really serious genetically based illnesses that have very high mortality rates. The recent statistic was that every 52 minutes, somebody dies as a direct result of their eating disorder. 1 in 5 by suicide. So I want to unpack what eating disorders are and how they relate to BPD. Every eating disorder, it doesn't matter which category you are thinking about, are defined by, I think, 3 main things. Every eating disorder is characterized by an inability to properly feed oneself. It's not a choice. It's actually rooted in metabolic factors and genetics. We're going to talk about that, emotion regulation difficulties. But people that have eating disorders struggle to be able to feed themselves and to manage what most people sort of take for granted: metabolism, weight, hunger and fullness cues. These things are all affected, whether you have binge eating disorder or you have anorexia nervosa. They're all affected. We also know now that all eating disorders are rooted in neurobiology. It's without a doubt now the genetic research, and I will speak to this as we go on tonight, but eating disorders have very specific metabolic and neurobiological underpinnings that drive them and maintain them. Right? Very, very important when we are trying to help people with eating disorders, right? Understanding this piece. And all eating disorders have characteristic symptoms and behaviors. There's a difference between having anorexia nervosa and having disordered eating, which is what is kind of the norm in the world, right? Disordered eating is sort of what most people are doing, but it doesn't mean everybody has an eating disorder. So there's very specific criteria, and I'm going to share some of that with you tonight. And as we're going through this, I invite you to think about yourself, the person that you are caring for that has BPD. And I want you to ask yourself whether you see any of this behavior as we sort of unpack these different diagnoses. And I'm willing to bet that quite a few of you either already know there's an eating disorder on board or suspect that there might be. Anorexia is the one that is most glamorized, most popularized, right? The one people think about the most. There's a couple of things I want to highlight about it. One, anorexia is defined by restriction of food intake, not refusal to eat. We used to say that back in the day. Are they refusing? Refusing imparts choice. The person is merely just being willful, doesn't want to eat. It's much more complicated than that. So in anorexia, you've got a person who is unable to take in enough food and fluid, and it leads to a significantly low body weight. And a low body weight that they can actually maintain in ways that most people cannot, right? So it kind of defies logic. If you've ever been around someone with anorexia, it's a curious thing. You know, how is it that they can maintain such a low body weight? Well, there's genetics in the background. There's an intense fear of gaining weight or any kind of behavior that interferes with the body changing. I don't feel like it's a fear of gaining weight per se. I think it's a fear of the difficult bodily sensations and perceptions that an individual with anorexia feels when their body shifts. These are very sensory sensitive souls. And so they will feel shifts in their body, bloatedness, water retention, weight gain, weight loss in ways that I think other people do not. And when they don't eat, it soothes that biology. It's very powerful. Some people with anorexia and across eating disorders may lack recognition or insight into the seriousness of their condition. And this is also rooted in brain mechanisms. We see this in schizophrenia and in bipolar disorder sometimes, where people are not aware of the dangers of their particular illness. Again, not choices, not people trying to avoid things. These are sort of part of the brain-based nature. We used to say that people with anorexia had to not have their menstrual cycle for 3 months, but that was problematic for lots of people, including boys and men. So it meant that if you were a boy or a man, you couldn't have anorexia. And so that's actually been removed. But a lot of people who can menstruate will actually lose menstruation as the body shuts down to protect itself because the weight is so low. Anorexia too can have a subtype of a binge purge subtype and a restricting subtype. A lot of people think that if there's binging and purging, that must be bulimia. It really depends on the presentation and usually the body weight. So people with anorexia, as it is written currently in the DSM, tend to have an abnormally low body weight. But so you can have some people that predominantly maintain that weight by restricting. They don't really engage in a lot of binge eating or purging behaviors. These are the folks that are exercising sort of relentlessly. I've got patients that are exercising on fractured hips and broken bones, and they're eating very little, versus people who may do some of those things, but also engages in binge eating and purging behaviors. So something to just be aware of. I put these on the same slide because it's sort of interesting how we try to differentiate between disorders. So BN is bulimia nervosa and BED is binge eating disorder. With bulimia nervosa, if you look on the left side of the screen, we would say, okay, people with binge eating or with bulimia have episodes of binge eating. Do people with binge eating disorder have episodes of binge eating? Correct. They both have episodes of binge eating. Binge eating is defined as eating an objectively large amount of food and having a feeling of being out of control. So if you ever try to stop someone in the middle of a binge, that can be a very emotionally dysregulating experience. Okay, so there's this sense of urgency and feeling out of control that goes on. In bulimia, there's the presence of compensatory behavior. So this is an individual who will, in a desperate attempt to get rid of the feeling or the fear of calories or so on and so forth related to the binge, will engage in self-induced vomiting, excessive exercise, laxative use, diuretic misuse, caffeine pills, anything to try to compensate for the binge eating, right? In binge eating disorder, the DSM will say that these are folks that don't really engage in compensatory behaviors, but this is a highly contested criterion. People with binge eating disorder absolutely do engage in compensatory behaviors. They're often the people that are on diets, restricting during the day and then binge eating at night. So restriction is a form of compensation. Okay, so there's this kind of argument right now in the field about, well, are these the same disorder or are they actually separate illnesses? The only difference between bulimia nervosa and binge eating disorder is body weight. Where people, this is the diagnostic criteria, where people with bulimia will be what they call average or slightly above average weight. People with binge eating disorder tend to be in the higher weight categories. Again, highly contested, a lot of controversy about this, or by defining eating disorders by weight. So I want to make you aware of that because this can be part of invalidation for people who have these particular illnesses. We can talk more about that. Both have body image disturbance. Both will feel very dysregulated and disturbed in their bodies. Both will have an intense fear. Again, weight gain. I think that beyond the sociocultural pressures to lose weight, I do think that eating disorder, folks that live with eating disorders really have very unique sensory and perceptual differences that makes living in their bodies incredibly difficult. And I don't think it's simply a fear of gaining weight. I think it's a fear of dealing with the discomfort and the disgust. Like my one client, she just talks about wanting to jump out of her skin all the time. She just hates being in her body. And it doesn't really matter what her weight is, predominantly. right? And both illnesses can be characterized by a lack of insight into the seriousness of their illness. A couple of lesser known eating disorders. One is pica. Far more common that people think, but most people don't ask about it. So this is when you have somebody that eats non-nutritive substances, paper, wrappings on cupcakes, soil, hair, paint. This is a type of feeding disorder. It's important that we are not confusing it with, I remember when my daughter was little, she put everything in her mouth, right? Does that mean she has pica? No, right? So you have to be able to differentiate from what is culturally or socially normative, what is developmentally appropriate. People have a lot of shame about this one, so they often don't tell you, they don't tell their parents. And also very important to rule out other conditions like autism or so on that might actually be contributing to that. So pica is really an interesting one that doesn't get enough attention. The other one is rumination disorder. And so this is one where the individual will repeatedly chew, swallow, and regurgitate food, and then re-chew it and re-swallow. And they can do that over and over and over again. Again, if you don't assess for it and don't ask, they're not going to tell you. And yet many of my patients have this behavior, and it's really damaging, right? Because you're impacting the esophagus, the gastrointestinal system. Right? So really important that if you suspect there's an eating disorder, that somebody who knows how to assess for these different types of disorders and their associated physical consequences is helping you figure out what's going on. Okay. The last one that is listed in the DSM, the Diagnostic and Statistical Manual, is something called ARFID, Avoidant Restrictive Food Intake Disorder. This is getting more attention in recent years. Usually this is happening in childhood, so you will see this in your kiddos. This isn't just picky eating. This is picky eating gone, in a very severe sort of manner. So you will have somebody that is unable to meet appropriate nutritional needs. There's reasons for that. That leads to significant weight loss. You might see a kid or a teenager that's not growing properly. They're not developing properly. Their height isn't, they're not following their growth curves. So those are sometimes clues that there might actually be this particular eating disorder going on. And the interesting thing about ARFID is that generally it's not associated with body image issues. Right. So unlike anorexia or bulimia, where we talk about this fear of weight or this fear of body shifting, the current thinking on ARFID, this is also contested right now by people with ARFID who say we absolutely do have body image disturbance. So I highlight those things to you because the field is evolving even as I present. So I want to make you aware of that as you learn about eating disorders. But in general, people with ARFID are not restraining their eating because of weight. There are different reasons, and I'll talk about those in a moment. But also important that, when you're looking at ARFID, this isn't the result of a lack of available food or culturally sanctioned practices or the result of another medical illness. So you need somebody that understands what eating disorders are. And there are 3 subtypes of ARFID. Okay. And some of you may notice this in your kids, right? So there's a sensory subtype. These are people that are avoiding foods because they have a lot of discomfort with the sensory features, the way it smells, the way it tastes, the textures, oral sensitivities, the colors, the appearance. So they will avoid foods because of the sensory aspect of them. This often coincides with a co-occurrence of autism or other types of neurodiverse presentations. But not everybody presents that way with ARFID. Some have a lack of interest. They actually don't feel the same hunger cues that most of us feel. And researchers have actually been able to detect that in this subgroup, they have differences in the way their hunger and fullness hormones are operating. So for example, you might have a kiddo with this type of ARFID presentation who comes downstairs in the morning. They haven't eaten since their evening snack, right? So you would expect them to be hungry. You cook a nice plate of pancakes And they come down the stairs and you say, okay, hun, here's dinner. And they say, I'm full. And the normal response is to go, that's impossible. You can't be full. Or for some people to say, well, that must be the eating disorder, right? Actually, what's happening in this particular subgroup is that they have an elevation in the satiety regulating hormone. So the brain is actually registering fullness even after periods of not eating. And if you've ever tried to eat when you're full, it's not a pleasant experience generally, right? But these are ways that a lot of patients are misunderstood. And then some of them have a fear of adverse consequences. So these are usually people that have had a choking experience or something bad has happened. They've had a severe allergic reaction, or they ate a particular food and it made them sick. They had food poisoning. And so now their eating world becomes smaller and smaller as they try to avoid that fearful thing from ever happening again. Finally, there's a catch-all because as Carol and others have said, we don't all fit into one box or 7 boxes, right? Not everybody meets those diagnostic criteria. Actually, a large number of people with eating disorders don't fall neatly into those categories I just explained. And so there is this other diagnostic label for people that have significant eating disorder symptoms that don't fall neatly into the other ones. Okay. Now, that is a crash course. I could spend 2 hours just unpacking the different diagnoses. So the first thing is just to know that there are these eating disorders. There's differences between them. There's similarities between them. But what does this have to do with borderline personality disorder? What is the relationship between these things? This very busy slide is here to highlight a couple of things. So when I teach my clients who have both, okay, they have an eating disorder and they have BPD, and they usually have other things going on, I have the you make sense conversation. It's kind of like my starting point, because these are usually the people that feel like they don't make sense. These are usually people that have floated in and out of eating disorder programs that didn't understand the BPD, but then they float over to DBT programs that don't understand the eating disorder. And by the time they get to me, they often feel like nothing's going to work. That there really is no pathway for them, and that they're inherently sort of broken or too sick or too complex. And what I do in this next section is talk to them about the fact that they're not difficult to treat. They're not too complex, but they're unique. And they're unique in a way that the field has not really brought these two areas together, eating disorders, DBT, okay? And so I start with biology, because I think a lot of people make sense when you think about biology. The first thing is that if you look at the top left quadrant where it says emotion regulation capacity, this is the section that we talk about with BPD, right? These are people that struggle with emotion regulation. They feel things intensely. They're sort of emotional super feelers in a lot of ways. And when they feel intense, it takes them a lot longer to come down to baseline. And there can be over-controlled presentations and under-controlled presentations. And in the interest of time, I'm going to leave that for a Q&A in case that comes up later. But our folks don't just have the BPD biology, they have the eating disorder biology. They have both. They have brain-based sensitivity to emotion dysregulation, but they also have genetic differences in biologies that make them prone to having eating disorders. Here are just a couple of them. Metabolic differences. Here's just one little nugget. We know that people with anorexia nervosa have genetic differences on 2 chromosomes related to metabolism. And what does metabolism do? This is where I wish I could just talk to you, right? Metabolism helps you regulate food intake. It helps break down food and distribute that into energy in your body. It helps with weight regulation. It helps with hunger and fullness cues. But now we know that there's actually abnormalities on at least 2 chromosomes related to metabolic functioning in those with anorexia nervosa, which means that they have a biology, a propensity toward toward not eating, toward low weight, and they're able to lose weight in ways that other people can't, right? There's genetics behind that. You cannot choose to have anorexia. You have to have a genetic underpinning for it. And the same is going to be true as we research more and more about neurobiology and the genetics of eating disorders. Okay. We know that there are also sensory and perceptual processing difficulties, as I've been alluding to, right? So this includes brain-based differences in sensory sensitivity, texture, sound, light, interoceptive awareness. That's the ability to detect what your body is trying to tell you. So a lot of people with eating disorders can't understand what the body is telling them. They can't detect hunger and fullness cues, for example. So the idea of just eat becomes very difficult for our patients. It's not just a matter of, well, let's just eat. You're actually bumping up against emotion regulation difficulties, metabolic differences, sensory and perceptual differences. We also know that there's reward threat sensitivity issues that happen with people with eating disorders. That is beyond what I have time to explain in this presentation. But these are some of the biological underpinnings for eating disorders. So let's compare that to borderline personality disorder. We know that there's a significant overlap between these two illnesses, right? Up to 53% of people with an eating disorder also meet diagnostic criteria for BPD. 53, over half of them. And conversely, when you look at studies looking at those with borderline personality disorder, again, about half of them have a lifetime history of an eating disorder. Those are very significant numbers. We know that both disorders are characterized by emotion regulation difficulties, and we know that there's a moderate genetic component to both of those illnesses. We know that impulsivity is elevated in both BPD and certain types of eating disorders, particularly binge eating and bulimia nervosa. We know that these are affected by things like dopamine and serotonin and reward sensitivity in both disorders. There's a lot of genetic overlap between these two things that we think is why they fall together so much. We also know that there are certain temperamental traits like negative affectivity, neuroticism, and novelty seeking that are genetically influenced and appear across both disorders. Right? So these are personality traits that actually can contribute to the development and maintenance of both illnesses. And there's always epigenetics. So epigenetics is, the way that the environment shapes the expression of genes. Early trauma, childhood abuse, neglect, bullying, sexual abuse, etc., interacts with genetic vulnerabilities, and it can increase risk for both. Right? So it's just important to sort of think about the ways that environments impact people's biology and then their subsequent coping mechanisms. There are differences in BPD subtypes across the eating disorders. Again, bulimia nervosa, we have a higher association with BPD. We think due to impulsivity and emotional instability. So this is that sort of under-controlled biotemperament, right? They're quick to respond. They're hard to sort of contain emotion. When they're feeling something, they act quickly, right? That's that under-controlled biotemperament, which makes things like binge eating or purging a little more available. Whereas in anorexia nervosa, in the restricting subtype, we have a lower prevalence of BPD. That's often because anorexia can be defined by a more over-controlled, sort of subdued, perfectionistic, compulsive type of personality, right? Which is different than most people with BPD. But those that have anorexia with the binge purge subtype are more likely to have elevated rates of BPD. But we know that biology alone is not enough to confer risk of an eating disorder or of BPD. We do believe that it's this transactional model. And those of you that are, trained in DBT know this very well. So what this slide is designed to do is highlight the ways that my clients, those that have both, are often invalidated. Right. So there's a lot of minimization and dismissal of their illness. So when we're not trained to think about eating disorders or the biometabolic underpinnings, a lot of times eating disorders are minimized by teachers, sometimes by families, sometimes, a lot of times by culture as just fads. Oh, they're just teenagers, they're just dieting, right? That these are choices that people are making. Oh, if he wanted to, he would just eat, right? We have everything from, insurance denials and inaccessibility to treatment. These are all ways that people's illnesses are minimized. Cultural and identity invalidation. So even those that are trying to get help for eating disorders and BPD are met with models that are pretty narrow in scope. It's very hard for them to find treatments that work for them. Lack of culturally diverse treatment options. The idea that eating disorders are really an illness of affluence. And so people in marginalized communities often don't feel like they have access to the treatment that they need. But some of the big ones are weight-centric and diet culture harm. So we live in sociocultural environments that are full of weight bias, fat phobia, thinspiration, fitspiration. I mean, my gosh, you can't go anywhere without seeing this. Whether it's a holiday dinner, TikTok, Facebook, your neighbor who you meet on the street, it's almost commonplace to talk about bodies and I've gained weight or I've lost weight or I've eaten too much or I'm so big or there's this kind of influence that we should all look a certain way and we should all be losing weight, especially in this age of Ozempic and GLPs, very damaging. And so there's so much more that goes on for people that have both of these disorders. And what happens is they don't want to talk about it. They don't want to talk about their eating disorder. They don't want to talk about what's going on. And it often goes underground. I think the recent statistic was that it takes about 7 years for someone with an eating disorder to actually get the help that they need. 7 years. And you add borderline personality disorder on top of that, makes it even more difficult for them. I'm going to just skip ahead here because I want to talk about, can DBT help? What can people do? What are some early things that people can think about? And I think absolutely DBT can help. And so I often talk with parents and caregivers about using your observe and describe skills without judgment and noticing signs and symptoms in the people that you love, right? The thing when you've got both BPD and an eating disorder is that things like suicide and self-injury, that's where everybody's focusing on, rightly so. But they often miss that there's other things going on or that these things don't seem as imperative or as acute as suicide and self-injury. So a lot of times as care providers, we get habituated to like severe crisis. So that when people are not eating, we're like, okay, fine, but they're not self-harming, right? And it's almost seen as a better symptom, if you will. Okay. So we know that. I want you to think about it and observe and describe. You might see that your loved one is talking about stomach problems, feeling fatigued all the time, dizzy, menstrual changes, dental problems, poor immune functioning. They may complain of constipation, cold intolerance. They may only eat certain types of foods. And they may just say like, oh, I just don't like this. I don't like that. But you're looking for patterns. They may have fears of choking, vomiting that you're noticing, that they're kind of always talking about. They may talk a lot about a lack of appetite or interest in food. These are all cues to me, this slide and the one after. These are all cues that if I'm seeing this, my advice would be to have someone who's trained in eating disorders to get their eyes on this person and just assess whether there's actually something there. I always say to my clients, you can't be emotionally regulated and have an eating disorder. It's like saying you can be emotionally regulated and be completely sleep deprived. It's not going. They're not going to fall together. The very nature of an eating disorder is to dysregulate the emotion regulation system. Right. So we want to be aware of these things happening and not minimize them. It's really, really important that if you see any of these symptoms, can you observe and describe them without judgment to the person? I think validation is, again, a power skill. I think the you make sense conversation is so necessary in these early stages if you're talking to somebody about an eating disorder. especially if they have, co-occurring BPD. I can see how hard it is to sit with food in front of you. It makes sense that this texture is a challenge, actually, given what we're just learning about sensory experiences. I would love to talk to you more about that, rather than, can you just eat? Like, just eat already. Just validating that for many people, the act of eating is not simple. It's very, very difficult. Or, another one might be, hey, like, it makes sense that you are drawn to restricting food intake. I don't like that you are, but it kind of makes sense to me because I was just learning about this genetic research that for some people, not eating soothes an unsettled biology. That's a pretty intense reinforcer. These are ways to have conversations about eating issues in a way that is not shaming, blaming, or making assumptions. It's giving people an opportunity to talk about what's going on, and what to avoid. Like, you just have to eat. Can you just do it? And I'm a mom. I totally get this, where you're like, could we just eat? That'd be helpful. Just get it done. We gotta go, right? And it's normal to do that. And if there's an eating disorder on board, that is going to exacerbate the emotion dysregulation. Actually, I have one situation right now where this is kind of the dynamic. Parents are really anxious, and rightly so. So at the meals, they're kind of hovering over their adult child. And the more they do that, the more she goes into her room after and cuts her arms. And this cycle goes on and on and on. And we got to break those patterns, right? But that's beyond the scope of what this talk is. Or saying to somebody with an eating disorder, that's not rational. This one comes up a lot around body image. So where there's that kind of classic cartoon that you see where you've got a silhouette of a very sort of thin person, it's usually a woman, and she's looking in a mirror, but the reflection in the mirror is of a larger bodied person, right? So you've got, right? And everybody goes, but that's not right. That's not what you look like. That's the eating disorder. That's really invalidating to people on both ends of the weight continuum, because we know that for many people, there are perceptual differences. They actually can experience their body shrinking, growing, getting larger, getting small. It's actually called Alice in Wonderland syndrome. It's fascinating. It's a neurological condition. Would love to talk more about it, but it's too much. It's too much. But so it's like saying to somebody with schizophrenia who's in the middle of a hallucination, well, that's not rational, right? You wouldn't do that, right? You would say, like, oh my gosh, this must be terrifying because your senses are picking up something that mine don't. Okay, so there's a difference in how so the learning of the biology, the learning of the invalidating environments helps us work with people that have these co-occurring conditions. I don't know why you have to obsess about your body all the time. Just leave it alone, right? It's not a mere obsession. It's actually rooted in sensory, perceptual, and much more going on. A few pieces before I wrap up. Mindfulness. I think mindfulness is, where we all must begin. The more you can observe without judgment. I was just working with a lovely family, and one of the things that was really causing more emotion dysregulation and a lot of self-harm behavior was that mom would, in her fear and sort of the eating disorder, would say to her daughter, you are being deceptive, you're lying. And my client would be like, but I'm not deceptive and I'm not lying. I'm trying to protect myself. I'm trying to feel better. So one of the first things I was doing with this family was I was saying, okay, mom, I want you to be able to tell me what you're seeing with your daughter without using deceptive or lying. So tell me what she's doing. Tell us what she's doing. No judgment. Within one round, within a week, mom did an amazing job observing and describing without judgment to both myself and the client together. And the client, she said to me, she says, I didn't like it. I felt sad, but I didn't feel the anger that I usually feel. Okay, that's big. So there's these shifts that happen when you learn about validation and mindfulness skills, describing the facts, not making assumptions. I know you didn't eat your meal. Do you actually know that? Were you there? You might not. You may be making an assumption. So it's important to just think about how we approach eating and weight issues. What to avoid. This is a hard one because of the culture we live in, but we teach not to label foods and bodies as good and bad. Maybe get away from that. There's good food, bad food. No, there's food. Food has different nutritional qualities. But we try to get away from this idea of there's a right or wrong way to eat and a right or wrong way to look. Okay. Assuming that eating issues are choices or talking negatively about body shapes and sizes. And there's no end to the amount of distress tolerance skills that we need, whether you have an eating disorder or you are caring for someone with an eating disorder. And so I teach families how to use the stop skill at a meal, how to help themselves or their loved one think through the pros and cons. You know, like what would it be like to be at the table with your loved one who's terrified of choking? And you say, hey, like, I see you. I know this is terrifying. Like, if you asked me to do the thing that I'm terrified of, I also would probably not want to do it. What are the pros and cons of not facing the fear? Right? Could we use the stop skill to just slow down and proceed mindfully and think through what's effective right now? Again, so there's a number of ways that you can use DBT skills to help someone that has both BPD and an eating disorder. You just want to be cautious because there's a number of skills that can exacerbate medical instability. Right. So everyone likes to use the tip skill, the temperature skill where we're using cold water, right? Put your head in cold water, right? That's a brilliant skill when you're trying to get someone not to engage in self-harm or suicidal behavior. But if someone has an eating disorder and there's medical instability, which is quite common, you don't want to do anything that might lower their heart rate or shift their blood pressure when it's already too low. So I'm just planting seeds to be aware that when there's medical stability issues on hand, you want to be thoughtful about what are the physical effects of a particular skill or strategy. I would say that it's unique. I think there's always, some similarities with all co-occurring conditions, but there's very unique genetic and metabolic factors that are specific to eating disorders that you wouldn't see, like say in OCD or substance use, that kind of a thing. So part of when you have any co-occurring, you have BPD plus, you want to lean into what do we know biologically and what do we know socioculturally about OCD, about substance use, about bipolar disorder. That's where the treatments hinge. So you want to make sure you know that. So it's important to know those genetic differences when you're treating a co-occurring eating disorder. That's a great question. Generally, when we diagnose one at a time. You wouldn't have bulimia and anorexia, that kind of thing. But there's a lot of crossover. So it's not uncommon. I think it's about 50% of people with anorexia cross over into bulimia, nervosa, can cross back, can evolve into eating disorder, those sorts of things. So there can be lots of crossover, and it's confusing because often, let's say you have someone with anorexia who gains weight, looks normal, right? Looks healthy, but is actually binging and purging multiple times a day. But everybody thinks they're better because they're not at a BMI that's really dangerously low. So a lot of eating disorders hide in plain sight. Actually, I would argue that the majority of eating disorders you would never know by looking at someone. You'd never know. So the first part is, what do you look for? If you know that your loved one has both, or that somebody here has both, okay, there are specific things that I would be looking for. One, I definitely want a team. I want a team. It's very hard to treat this co-occurring presentation by yourself. So I would not want to do it, even with all my years. I would not want to do it by myself because there's just so many moving parts. There's nutritional needs, there's medical needs, there's understanding suicide and self-harm, there's understanding how to help feed somebody. Woof, that's a lot of stuff, right? So you want a team that ideally is DBT, comprehensively DBT trained, okay? That is usually people that may have a BTEC certification or that they have undergone some significant training and supervision. Okay, and I would be looking for full comprehensive DBT, not a skills group. I've tried it. People need more than that. So on one side, I want people to know what it means to have emotion dysregulation. I really want people to know what that means and how to treat it and how to treat all the things that go with it. The invalidating environments, the traumatic invalidation, the fact that it's so hard for you to deal with emotion and regulate emotion. I need people that understand that. Okay, that's the first part, but it's not enough. And it's not enough because when I started years ago in the BPD clinic, right, and we would treat people with eating disorders, but they weren't getting better. They liked DBT, but they would still have anorexia or bulimia from the beginning to the end, right? They might not self-harm, they might not be suicidal, but their eating disorder remained largely intact. And that was what started my dissertation. I was like, this doesn't make sense. This doesn't make sense. Because often the DBTers will look at this and go, it's an eating disorder. It's a problem of emotion regulation. And they'll try to treat it like it's self-injury, but it's not. It's not. There are very specific biometabolic factors that you need to know how to treat. So you need people that know DBT because you got that BPD going on. But you also need people that understand eating disorders. Okay. Now, this is a growing area. There's a lot of programs now worldwide that are trained in both, which is really exciting because 20 years ago there weren't any. But you want a team that knows both. There are treatments like MED-DBT that are specifically designed for this particular subgroup of people. So you might be looking for things like who does MED-DBT, where is that training, who does that work, but I would want minimally that. I also look for teams that either have or have relationships with physicians, dietitians, right? So that you or your loved one can get the support that you actually need when you're doing this. So that's the first part, is that.
Go with
I think the loved ones are desperately needing support, but not the usual support. They're usually pretty burnt out. They're usually, and I actually think, Sashbear, you know this better than anyone. What do the loved ones need when they're burnt out and they feel misunderstood and their kids are suicidal and self-injurious? It's no different. My experience is that caregivers, when you say to them, I actually am going to do a support group that has both, I'm inundated with people. Now, there's always going to be parents or caregivers that can't. They have 3 other kids. They work 2 jobs. They don't have the money to pay for it privately if it's private. And I do a lot of DBT commitment work with parents and with clients. When we talk about what are the pros and cons, I think parents are essential. I don't care what age. I don't care what age. I think that they're so essential to this process. And I think so many parents are struggling with PTSD and other things. To have a kiddo with BPD is a kind of trauma. To have a kiddo with an eating disorder is a kind of trauma. You don't know if they're going to be alive or if they're going to die from medical instability, from suicide. I mean, it's awful. These parents to me are the heroes, right? Like they are trying to figure it out in a system that actually was never built for them or their kids. So one of the things that I'm trying to build, and again, with people like you, is how can we get more support to caregivers? Because I actually think they're looking so hard for it. So first you got to build it, you got to offer it. But I think there's a lot of concepts that you could be teaching caregivers that would be helpful. But at the end of the day, you can't force people to do treatment. That's the other piece. Like I can't force a parent and I can't force a patient. And so as some of you here may know, in DBT, we have a pre-treatment phase, which is designed to enhance engagement and commitment in a population that is quite ambivalent. That's the whole nature of it, right? And that is the reality for many people. They have to take what's available. I guess what I would say to that is that as far as the chicken and the egg piece goes, I mean, if I'm assessing somebody and there's ARFID, right? And they have sensory issues and they really don't eat because of sensory difficulties, but they're also suicidal and self-injurious. And there's trauma, right? Like, you know, what do you treat? How do you organize yourself? Well, that's what DBT helps you do, right? As a clinician, I say, what could imminently kill you? So I'm not actually interested in necessarily what came first. I'm interested in what is imminently life-threatening. So if you not eating means that your heart rate is in the 30s and you could go into cardiac arrest at night, yeah, I'm going to target your eating. I'm going to go hard after that, at least until you're not in harm's way, right? But if your eating is problematic but not life-threatening, I'm going to prioritize self-harm, suicide, before I'm going to necessarily get to some of the eating issues, but I'm going to keep my eye on all of it. It's kind of like with trauma work. You know, sometimes people come in and say, I want to do trauma work. Why won't someone do trauma work with me? And I say, well, the first layer of trauma work is making sure that you can tolerate distress. Because if every time if tolerating distress means you're going to try to kill yourself, or you're going to purge 3 times a day, I'm not going to go there. We got to build up some reserves. So we are doing trauma work. We're just doing it in a very staged way. And so it's the same here. You've got to know. That's why people that treat both need to understand what are the medical consequences of the different disorders, right, so that you're aware of what could be imminently life-threatening versus problematic, but it's not going to kill you today. If that makes sense. Yeah. So first of all, stress eating, emotional eating, I don't want to overly pathologize that. I mean, I don't know what everybody's different cultural backgrounds are, but as an Italian, I can tell you right now that, yeah, food is a very comforting source of support, right? Like, you know, when you think about, like in this example, death or grieving, I mean, that's kind of par for the course, is that you get together around a lot of food and a lot of community, and you know, you cook for people and you eat. And this is why people in breakup movies are like, I'll get the Haagen-Dazs, right? Like, there's a reason for that. So we don't want to pathologize all emotional eating as bad. So I would ask more questions. I would want to understand first, has there ever been a problem with eating prior to the death of this person? Are there other factors that might make a person at risk, right? So you might have someone that's never had an eating disorder, and then life happens and they have the genetic underpinnings, right? So that this may actually turn into an eating disorder. So I would probably keep an eye on it. I'd probably want to understand it. It may become an eating disorder. It may not. It may tell me that this person needs help managing intense grief and loss. Mm-hmm. And emotional eating can be one of those coping strategies, but you don't overuse it, right? So if you're overusing it, it's like exercise. I think exercise can be great, right? We all know, right? Number one thing for depression, right? We go exercise, right? It helps your mood. But if exercise has been part of your eating disorder and it's how you try to control weight and shape, I don't want you to rely on that as your sole way of regulating emotion. That's a problem. So, you know, the answer to that really comes down to a really thorough conceptualization of who is this person, what is going on here. That's why you want people. So when people are seeking treatment, that's you want, if there's ever eating issues, it's really nice to have somebody who can assess for that, because they'll know what's going on, whether there's something there or not. That's an excellent question. There's a significant relationship between medication and weight and appetite. I mean, this is really hard for people with, I would say, BPD, with mood disorders, with schizophrenia, with psychosis, who are often prescribed medications that impact not just their mood. It's the same region of the brain that controls weight, hunger, fullness cues. So on one end, you'll have a lot of people who who will gain actually a lot of weight, like above where they're genetically predisposed to be, right? They may feel better. I remember I had one client years ago. She tried every medication, nothing helped, right? She finally started this medication, and it was shocking to me how grounded, stable, happy she was. Like the two of us would be like, oh my God, this is like the Holy Grail, right? You found it. But her weight in a very abnormal way, even her physician was like, this isn't, just kept going up and up and up, causing a whole host of other problems. And she was heartbroken because she's like, I finally feel okay, but I can't tolerate this never ending weight. And then people in her life would judge her for going off the medication. She's being difficult, not appreciating how painful it is when you've got an eating disorder, living in the earth suit that you've been given, right? It's like full of sensory and perceptual, landmines. I don't know another way to describe it. And so what might seem like, so you're happier, like, God, who cares what you weigh? It's like, it's torture. It's another kind of torture. And I think a lot of people don't understand how difficult it is to be in a body that has an eating disorder. And then you have BPD, right? It's just like, so hard. I was just talking to a group of clinicians this morning about how it can sound almost ludicrous to patients when you talk about building a life worth living, when it means living in a body that feels foreign, and when it means living in an environment like the one, Carol, that you're talking about, right? They think we're nuts when we think, when we talk about recovery, because they go, there's so much noise. There's so much noise, right? So there's many strategies, and I'm so thankful to Marsha Linehan and DBT for this, because if you think about what Marsha Linehan did, right? She took an illness, borderline personality disorder, that was deemed treatment resistant. So much noise around that disorder. Still is, but not so much, not the way it was in the 70s and 80s. And she revolutionized how to recover and thrive when people see you as treatment resistant. That to me is a brilliant legacy and always motivated me, because it's the same for my patients. I say, these are the ones that have been deemed resistant. They've tried all the eating disorder programs. They've tried DBT, standard DBT, nothing works. And now, in a terrifying development, we have proposal for terminality, which is the exact same patients that I treat, right? I say, wow. So it's a very scary, there's a lot of noise around a lot of things for our patients, for our clients. One, if you are a loved one, you absolutely have to express care and concern and ask questions. That's our job. We got to do it in a way that doesn't lose sight of what makes sense about this person, right? So, I'm sure you learned this in your family connections groups, but, how do you talk about your concerns in a way that isn't invalidating or blaming? Okay. So I never want to shut down a caregiver. I think you need to be able to say, hey, I'm worried. This is not okay. This is concerning behavior, in a way that isn't blaming. I spend most of the time talking to clients and their loved ones around, how do you respond to the noise? Because it's there. I can't take it away. Like I have a client that graduated from a pediatric program, 17 going on 18, did a kick-ass job, pardon my language, did a great job, goes to see the pediatrician. 3 months later, the pediatrician says, you've gained a little bit too much weight. Like, how am I going to protect my client from that? Because it's going to happen. It's going to happen. So instead I say, what are you going to do? How are we going to cope ahead? What's your dear man? When your physician says, I need you to get on the scale, or they make a comment about your weight, there is something beautiful about alternate rebellion, right? About empowering people and parents. And how do you use your skills when you feel deeply hurt? How do you not go back to your symptoms to cope with the invalidating environment? There's a lot of work to do here. It's hard for me to explain it in a short amount of time, but it starts with everybody that's here, right? You are the environment. You are. So if the 194 people that are sitting here right now all practiced getting away from diet culture, that would have a massive impact on your loved ones. I guarantee it. The kicker is that most of us don't know just how internalized diet culture is. So a lot of times we're doing things because we actually think it's helping our loved ones. Let's go for a run. Let's drink the diet pop, right? Because we're going to protect them. I had a dad that, God love him, he was blowing up all kinds of treatment settings because he was so scared to feed his son the way that the program wanted him to feed him, right? In normalized eating. And everybody thought he was just, difficult, right? So I sit down with this dad and I said to him, what is your relationship with weight? And he was a little tough. He was like, this isn't about me. I was like, I don't know. I'm just curious. And in an hour, I learned that this dad grew up in a different part of the world, different country, and he was weight and shape based bullied from the age of 7 to 16. And to this day, will not take his shirt off, even at the hottest beach ever, 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 because he hates his body. And I said to him, I said, so you're trying to protect your son from that, aren't you? And he, the look on his face, I said, you're not a difficult dad. You're a terrified dad. So let's talk about the pros and cons of doing this with your son, right? But he made sense to me. Like, you got to get to that place with people. You can't blame a parent for having internalized diet culture because they grew up with it. We all did. Everybody here grew up with diet culture. Everybody here. Anyway, so there's so much we could talk about, but
and they're all different diet cultures, right?
oh,
So that's where all that
many.
and that's where all the judgment comes in.
Everybody has a relationship with food, and everybody has a relationship with body. You can't not. So everybody has opinions about what is healthy weight, what is healthy eating. Everyone does. Part of the work in loving someone with an eating disorder is doing a bit of work on yourself. I always say, work with the parents, work, even if the kids aren't in treatment. Parents are the lifeblood of so much of what goes on, even with your adult kids, it doesn't matter. There's so much that parents can do. I really, I have a lot of respect for the parents that stay on this journey and keep fighting. Takes a lot of tenacity to do it.
Thank you so much. Thank you so much for sharing with us. I do want to give you an opportunity. People are asking about resources, and we did talk about this before, that at the Hospital for Sick Kids in Toronto, they have an on-demand course. Correct. So I guess people could check that out at the Hospital for Sick Kids, their education. But they have an on-demand course that has multiple sessions, and it does talk about eating disorders and BPD. So that's one there that everyone can go check out. That's available on demand. So.
Yeah, you don't have to be a clinician. They marketed it as, what every clinician needs to know. When I did that, it's 9 hours, but it's in modules. But when I did that, it was what I wish everybody understood about eating disorders, and where we really break down these constructs. So, but, feast.org, there's a lot of places out there that do incredible work that would help round out the BPD side to help families better understand eating disorders, for sure.